morning, everybody. I would like to welcome all the scleroderma patients, physicians, and all the family members who are here today with us for our first scleroderma update organized by the conjoined forces of McMaster University and Scleroderma Society. I'm really privileged and humbled to be the first speaker to start off the day. My name is Kaminska. I'm a clinician rheumatologist at St. Joseph's Hospital and McMaster University. I've been involved with patients with scleroderma ever since very beginning here in Hamilton in 1992. And I have remained so till today. And I would like to thank you all my patients who taught me a lot about the disease and actually allowed me to become a better physician and better practitioner and sort of walk the walk along with you and make it easier for you as much as we can. So I have been given the title or the topic of scleroderma medical update, and when I got into reviewing what's out there in the literature, I found it totally overwhelming, and the number of slides that I amassed preparing for this talk would take us through the whole week or maybe even more. So I had to somehow streamline it and condensed, and so it's by no means a fully comprehensive talk, but it will touch on what's changing in scleroderma, what already have changed in our understanding of the disease, of our perceptions, and some research leading to changing outcomes. Scleroderma was believed to be an orphan disease. Nobody knew about it. We are, with all of you and other people around the world, societies like Canadian Scleroderma Research Group and some French groups in Europe's organization, like Canadian Rheumatology Association, Arthritis Society, is the American Rheumatology College of Rheumatology, as well as EULAR, the European organizations. We are bringing it forth. And by unifying all the patients who up till now were scattered all over into one big group, by participating in the databases, we are able to provide, hopefully, some answers now and more answers in the future. So again, anyone who agreed to participate in our trials and databases, thank you so much. So the topic that I sort of subtitled to the talk is the scleroderma, the time they are changing. And I really hope that this will be a prophecy of the future time. So I have to give credit to Dr. Mark Larche for reminding us that we've had some famous people among sufferers with scleroderma. Paul Klee, you may know him as a painter, abstract painter, French from the 30s, 40s. He suffered from the disease, and I think we may find some of the images in his paintings, like the mask that you saw at the introductory slide. Pathogenesis of scleroderma has been very complex, and the understanding is increasing. We know that we have end organ damage, and for the longest time that's where a lot of research concentrated on the fibroblast and the amount of fibroblasts, the amount of collagen. However, right now we know that a lot of action is happening in the blood vessels, and the faulty blood vessel, faulty regulation, and application of the lining of the blood vessel, muscular mucosa, leads to the damage. And that all happens in the patients who carry some genetic susceptibility. There is environment like silica, some solvents that have been proven to affect it, tobacco exposure, and leading to the inflammation and activation of the immune system. It's a very common disease. Incidence about 20 cases per million. The 200 patients, 250 patients per million in United States. Every race, every gender is affected. There are certain patients who will fare worse, like men patient, Asian patients, or black patients. The certain association happens with the autoantibodies. I'll mention about those. There are some twin studies that also indicated some genetic predisposition, and I have several patients in my practice that there is mother and daughter who are affected by the disease, or cousins and brothers and sisters. Survival has improved over past decades, and that's the most encouraging, and that's what I would like to concentrate. And as I mentioned, there's some evidence for occupational causes, but there is no clear association, maybe with the exception of toxic oil and some tryptophan ingestion that was related to, again, contaminants within the tryptophan supplements. So it's predominantly disease of the females. If you look at the pink and purple lines versus the green and blue, you will see that the female predominate. They are affected by the disease earlier in the 20s and 30s. And there again, the race, black race is affected much more than the white patients. The incidence being up to 60, 70 per million per year. With the development of the groups of the databases, what we see that we realize the disease is much more common than we realize. So if we look at the early studies, prevalence was noted to be 4 per million. Bernatsky, which looks at some Canadian experience, gives us the number of 443, and we are still discovering more patients. They are being referred and diagnosed with the increasing awareness among the general population and also among the treating physicians, primary care physicians. In terms of new things that have been happening, we are getting deeper understanding of immunology of the disease. And the autoantibodies have been known to be present in Scleroderma. And the two antibodies that we have seen most commonly were centromere antibody as well as topoisomerase SCL70 antibodies. But with new development, there's more antibodies being detected, as you can see. And with new assays, they are much more readily available. They are available faster because they are based on the so-called ELISA tests that are really quick, and they are not observer dependent. You can imagine that this, which is called immunofluorescence, is very much technician dependent because they will have to manually prepare the slides. They will, each of them, have to treat with certain antibody with fluorescein, make them light up, and then look and analyze each of them and decide which pattern they have, and then titrate them to give us a titer. This is all automated right now. So instead of waiting 2-3 months for maybe not months, weeks to get the report, we can get them almost instantaneously. So huge change in terms of diagnostic, which is very, very welcome. These antibodies have some prognostic values. As you can see, topoisomerase carries worse prognosis. That's the one that often is linked to very aggressive diffuse disease with the renal involvement. And also antibodies, so-called U3-RNP, that we do see in the condition called mixed connective tissue disease, also carries a little bit more difficult prognosis, particularly as far as vascular complications are concerned. We know that scleroderma is a multi-system disease, and this is the frequency of various organs being involved, as reported by Dr. Steen and Dr. Metzger from Pittsburgh. They, up till now, had one of the largest population of scleroderma patients who were followed systematically for a number of years. The period of observation nowadays must be up to 40 years, I believe. So in their experience, about 24% have skin. You know about the condition scleroderma without scleroderma. It's not common, but does exist. So the patient may have all the internal organ involvement without hardly any manifestation from the skin. And these persons are often misdiagnosed, or they are diagnosed with the very late stages of pulmonary hypertension or GI involvement, or even kidney. The pulmonary, 16, renal, and cardiac involvement. In terms of the survival data, we see huge improvement, and that comes with the new diagnostic techniques, earlier diagnosis, proper management. Even though we don't have a cure, we do have symptomatic management that makes huge difference to the patient quality of life and also survival. So when you look at the early cohort, the 10-year survival was about 60%. More recent is 76%. Dr. Mayer's more recent paper has a surprising values of 55 that it's not quite explained. She has, her patient population is from a slightly different region rather than across the country. I think she is from the northern, she's Detroit area, isn't she? Houston, is she? Okay. Now, in terms of the survival, it's important to realize that being given the diagnosis of scleroderma, even though to many of you it is a very tragic moment, it does not necessarily mean that there is a serious long-term problem. And like with any diseases, lupus or rheumatoid, there will be patients who will have a milder disease, and there will be one who have more severe disease. And if you look at these two lines that are quite nicely separated, they again talk about 100% and over 20 years, how many of those patients will be alive. If you follow the blue line, that means there is an internal organ involvement. These patients will definitely have a harder go with difficulties with either kidneys, lung, heart. Without any organ involvement to speak of, the survival is much, much better. And it's changing and improving as we speak. So I will start maybe moving on to the specific organs. And the first one that really was the key organ leading to mortality and morbidity in the early years of scleroderma was the scleroderma kidney. I'll just go back for a second. So this diagram shows you the vasculature of the kidney and the way the Raynaud's affected the kidney and pruned the relatively normal blood vessel tree to the one that has been heavily pruned and devoid of the microvasculature. And you can imagine that the kidney is going through the same vasospasm and changes like your hands are going through. And this is the angiogram where the dye was put in. I found it on the internet. We stay away, unless we absolutely must, from the dye studies in scleroderma patients because of the possibility of actually precipitating some events like scleroderma crisis, but nonetheless, this is the study that was done, and you see that there is, again, pruning. The blood just finishes in here. And that's a nice diagram showing you the artery and the vein and how they intermingle in the middle, and the yellow as ureter as leads the urine out of the kidneys. So prognosis, prior to 1970, only 10 to 20% of patients will survive the attack of scleroderma renal crisis. And that's the condition that presents itself with rapidly rising blood pressure, severe headaches, confusion, often congestive heart failure, and rapidly rising creatinine. The kidneys stop working very, very promptly. And because there is that shutdown of the blood flow to the kidneys, the red cells are also destroyed, so the patient becomes anemic very, very quickly. And before the introduction of the medication called ACE inhibitors, the mortality was very high. And most of the patients would die very, very early, and practically whoever survived was remaining on dialysis for the rest of their life. Currently, we see that the mortality in diffuse scleroderma is 5% and in limited 2%. The scleroderma renal crisis is more commonly seen in the diffuse and generally in the very early stages of the disease when the skin starts tightening up, when there are muscle contractures. So that is a subtype of the patient that we have to be very much on the lookout early in the disease. And mortality is greatly improved, less than 15%, 5-year survival, 65. So the first ACE inhibitor was captopril, but there are new ones on the market that have been helpful. And I want you to pay attention to this slide. These are the patients who, unfortunately, they lived through the crisis, but their kidneys never recovered, and they remained on the dialysis. So their outcome, as far as survival, is not as good. The middle line is the patients who never had to go on dialysis. The crisis was controlled with controlling blood pressure with the blood pressure medications. However, they don't do as well. And the interesting part is, if you look at this, these were the patients who actually went on dialysis. And then within the next 2-3 years, their renal function recovered. And they actually are doing, at least in the study that is reported here, they've done the best of the group. So even with in the acute presentation, one has to keep optimism because there is first of all, the chance of recovery of the renal function, and the survival is good. The next one, which is also interesting, is the kidney transplantation. When I was going through training, internal medicine, and well, I didn't think it was that long ago, but when I think about it, that was about 20 years ago already. Scleroderma patients would never come to the transplantation. This was a no-no. You had scleroderma, you were doomed. There was, I guess, not enough organ donors around, not enough kidneys, and it was felt that the kidneys would be wasted on the scleroderma patients. Well, that has changed, and this is the data from the USA registry. So for the past almost 20 years, they had 258 patients who were listed for the transplantations. And their graft survival for 1 and 3 years, it's quite respectable, 68 and 60%. They noted that there has been early loss of the transplanted kidneys. However, they still are qualifying for the transplant. And interestingly, their survival of the patients who did go for the transplant was markedly better than if they stayed on the dialysis. And in the author's experience, and they had 4 patients in that cohort of 250, the skin scores improved almost immediately once they went and were transplanted. So again, this is old data, 2004, and I didn't come across anything more recent, but I'm sure that the scleroderma patients are there, so maybe we, as a part of our group, will be able to fish out the information about that. So this is one of the paintings by Paul Klee, and when I saw these paintings for the first time, I didn't know that he had scleroderma, but now when I look through the eyes of the knowing the scleroderma patient, I think that I can see some of the features in this mask-like portrait. So that gives me a key or clue to switch the gears and again point towards what's happening in the scleroderma management over years. So we've talked initially about scleroderma renal crisis. So you see the white bar, and the white bar remained high into 80s, 82. This is the event where the ACE inhibitors became available, and look what happened. There where we are with scleroderma renal crisis. It's no longer a leading cause of death for scleroderma patients. So proportionally, what has been happening, that other problems are becoming more prevalent. And the one that really took the lead or takes the lead is the interstitial lung disease, scleroderma lung disease. And the next one is pulmonary hypertension. So these are the ones that right now we pay more attention, and fortunately we have some new developments in therapies that make the prognosis and the future brighter. So the scleroderma lung, this is an example of the lung that instead of being very airy, almost like spider web, you can think of it, tridimensional spider web, very, very light and fluffy with nothing there. It's meaty, it's almost liver-like consistency. It's very hard to breathe if that happens. Fortunately, if you remember the percentages, only very few patients will really have a serious problem like this. Some of the patients will have a different problem, and I'll mention that later, which is also related to the lung, but it's to the severe blood vessel constriction and pulmonary hypertension. So in here you'll see that there may be fluid around the heart, there may be thickening of the lining, and you recognize the typical appearance of the scleroderma patients. Pathophysiology of interstitial lung disease is very complicated, but we are gathering more and more insight in it. And I don't intend to discuss all these different players, but I just want to point out to you that endothelial cell, which is the cell that lines the blood vessels, is put right on top, and it's felt to be a main player. There are T cells, B cells, there are some fibroblasts, and a lot of talk is happening between all these cells. Some of the players we recognize very well. TGF-beta has been studied for a long time. It's tumor growth factor. PDGF, it's platelet-derived growth factor. Endothelin-1. Endothelin-1, we do have very effective drugs that block that profibrotic and vasoconstrictive molecule and moiety that's in our blood. We do have other ones that we already have the drugs available, like IL-6, which is already approved and used in rheumatoid, called Actemra. Their interferon gamma, it's already used for other treatments for multiple sclerosis. There are other interferons used for hepatitis. So we have technology to develop these drugs. So the more we know about the players, the better we can interfere, hopefully very specifically, rather than with a broad immunosuppression that carries a lot of toxicities. So we carry on still with the lung, and what I'm going to talk right now is about the new development in diagnosis. Again, technology is moving on. You probably know that maybe even 10 years ago, maybe 15 years ago, a lot of patients had a lung disease, but nobody knew about it. And the reason was that the chest x-rays were normal. The doctor might have listened to the chest, said, okay, you've got a little crackles at the base, but chest x-ray is fine, fine. And because your skin was getting tighter and tighter and you did less and less, most of you might have not even noticed that your exercise capacity has been going down, because naturally we adapt to what we need to adapt to. So the chest x-ray was very useless. And the chest x-ray does not really detect early disease. The chest x-ray detects when the disease is already in the scarring phase, pretty much gone. And the early trials of treatment in scleroderma lung really address that stage of the disease. So the good outcome, of course, won't be there. So then we had the CAT scan, which is computerized x-ray, and then the high resolution, the FRCPC, which allowed us to really map the whole lung by cutting it in tiny little slivers and then restoring it in different dimensions. So this is sort of cutting it that way, but the computer can also reconstitute it in the coronal plane, giving us a very good look into anatomy. And what we've realized that there are a couple of types of lung abnormalities. One is so-called ground glass, which is more inflammatory, sort of fuzzy, sometimes is very diffuse, but often only at the basis, called non-specific interstitial pneumonia, NSIP, or more scarring type of abnormality called usual interstitial pneumonia with a honeycomb-like appearance. So they have different prognosis. And again, there is a lot of change and a lot of research happening. This is a non-invasive technique. An invasive part of that is the amount radiation that the patient receives during that test. So we have to think twice before ordering it. Now, the further diagnostic advances are happening. Bronchoalveolar lavage is going into sort of back burner. It's an invasive. There is no uniform, there's no agreement how useful it is. So because of difficulties performing the test, it's very difficult on the patients who have lung problem to begin with. Induced sputum instead is being studied, much easier. The next thing is exhaled nitric oxide, and that can be measured. And the premise is that there is an upregulation of nitric oxide synthetase in the lungs, and if there is an inflammation. So that can also give us an idea to what extent the lung is inflamed. There are further imaging technique, the computer-aided diagnosis technique, and that's a difference between the usual CAT scan, high resolution, and that computer-aided. So with some gimmicking that the physicist can do, you could see how much disease is in the lung, which didn't look too bad on the first scan. So there is another imaging technique, denoising, again playing with the windows on the CT scanners, trying to fish out if there is any problem. And the next thing is really trying to be more accurate and systematic in trying to say how much disease in the lung. Oh, you've got a little bit on the basis. Oh, well, we'll see you next year, a little bit at the basis. And that little bit on the basis, 10 years later is oxygen therapy, because there was never enough of the disease to say, okay, we should be treating it aggressively. So this algorithm that tells us what's the percentage of the lung being involved with the ground glass, plus some pulmonary function tests, and specifically forced vital capacity, FVC. So one of the numbers that when we look at the bone scan, at the pulmonary function test, there are all these little squiggles and numbers, and there are few that we pay more attention than the other. And FVC is the one of them. So the magic number is 70. I'm surprised they didn't include here DLCO, because there is a magic number of 50 there, which also carries prognostic values, but it wouldn't have to do with interstitial lung disease, more with a vascular lung disease. So if you have extensive disease, you would treat. So advances in therapy. Maybe I'll start with the bottom part, cyclophosphamide. That has been around for a long time, and up till recently there were no double-blind controlled studies. There were observational, and again, usually they were rescue situation where the patients were very ill, disease was extensive, so it was not very successful. But up till now, there have been 3 randomized control studies. There were some observational studies that, whereas they did not show a lot of improvement, they did show arrest of the progression, which if you are in class 2, meaning you can practically do everything short of running upstairs, and you stay like this for the rest of your life, I think we are doing very well. Thank you. We would like to do better, but it's not bad. Plus quality of life was looked at, better. Shortness of breath, better. Rituximab, some rescue treatment, which is interesting because these are the patients who already had been on prednisone and cyclophosphamide, and they have responded to rituximab. Mycophenolate mofetil, it's kind of sneaking up into our drug armamentarium. It was used in the transplants. We've started using it in rheumatoid, not very successful, but nevertheless it's there, and it's quite safe, quite well tolerated, and even better, there is a mycophenolate sodium that is covered by the government. I don't have to write a single letter to get that drug, which is beautiful. And I have to thank the pharmacist that I saw here today who told me about that a few years back, and I'm eternally grateful to her, and my patients are grateful too. So imatinib, there is a biologic. This is one of the new drugs on the horizon. It inhibits inhibits tyrosine kinase and acts on platelet-derived growth factor. And the beauty of this drug that it's given by mouth. So there are studies ongoing. There is no final studies, but there's a lot of hope with it. And I have to admit, I did not come across IL-13. I think I ran out of steam. But it's out on the horizon, so things are coming. So just the biggest scleroderma lung study, the point was that there was arrest of the disease, and the 24 months follow-up, they said, oh, the patient lost all the benefit. But the thing is, after 1 year of treatment, they dropped, and they have not offered any maintenance therapy. And I, being a clinician for many years, I believe that there should be maintenance. And there are good drugs that can be used like as a maintenance, for instance, mycophenolate mofetil or Imuran for certain patients. So this is from the same study. This looks at all the patients on limited scleroderma and diffuse scleroderma. This looks at forced vital capacity, and that looks at the, I think, tidal capacity. Whichever you look at, this is the placebo. Oh, I'm sorry, no, I'm lying to you, sorry. So the placebo is losing ground no matter how you look at it, how you divide it. The cyclophosphamide over 12 months is staying the same. So it takes some time for the drug to kick in, and we know that. So that's probably where you see this first dip, because they go parallel. Bosentan, we talk about it mostly in the context of pulmonary hypertension and ulcers in scleroderma. However, it has effect also on inhibiting fibrosis, because endothelin-1 is profibrotic. So there have been some post hoc analysis from other studies that looked at the progression, and what they found that in general there has been no difference if you just took all comers with lung disease. However, if the patient had a lung biopsy, open lung biopsy, this group did better for whatever reason. So there is a trial ongoing. So another interesting part is advances in transplantation. So there is a hematopoietic stem cell transplant, autologous stem cell transplant, and also trial looking at scleroderma, cyclophosphamide versus transplant, trying to see which one will offer the patient better chance of survival. I think at this point in time, this is for people with a very poor prognosis, with fairly advanced disease, because mortality, even though improving of the procedure itself, it's a very gruesome procedure. There's a lot of radiation, chemotherapy, preparing for the lung transplant. So it's not, or hematopoietic stem cell transplant, but they are quite involved. And I sort of touched about lung transplant that I'm not going to talk about, but again, lung transplant is an option for scleroderma patients, although outcomes are not very good because often esophageal involvement. And that actually, okay, so I'll just maybe mention about that. Acid reflux has been underestimated in being a culprit in causing lung disease. I don't think we know exactly what is the percentage of the patients who have the primary immunological pneumonitis. My feeling is that probably about 80% is happening due to acid reflux. And whoever had a pleasure or displeasure of meeting me in my clinics and me bugging you, you have reflux. No, I don't. I don't have heartburn. I'm fine. But you are coughing. I'm not coughing, but you are clearing your throat. As long as you are clearing your throat, you have reflux. And we go on and on and on like this. The point is, in scleroderma, because of long-standing reflux, you lose the perception of the heartburn very quickly. And the only perception you may or may not get is sore throat, losing voice, chronic sinus infection, chronic pneumonia, and often subclinical pneumonia, or not pneumonia, subclinical aspiration. So it just sits there and fosters in your lungs, causing all these bubbles and scarring, and that's preventable. So are you using 6-inch bed elevation? Well, I use 3 pillows. Are you using 30 or the wedge? No, I use 3 pillows. So this is sort of discussion. It's very, very important because this is the leading cause of real trouble right now. This slide, very quickly, several studies, 29, 670, 17, 13 patients, all positive, mycophenolate. We have it. This is the summary. I don't want you to even attempt to read, but that summarizes things in terms of the drugs, rituximab, mycophenolate mofetil, imatinib, methylprednisolone. This is the drug that we treat very gingerly because of implication in renal crisis, cyclophosphamide, transplantation, and cell transplants. And so we covered all that. So we are moving to the next stage, and again, Mr. Clay, scleroderma heart. So that's a nice depiction of the heart and lungs, and you will see this what the normal lung would look. Well, actually, I disagree with that. Okay. So normally the pulmonary artery is quite regular size and it's narrow. In the pulmonary hypertension, there is increased pressure on the right side of the heart, because you can imagine as if you put sludge into the blood vessels in your lung, so it cannot go through the lung back to your heart full of oxygen. It really has hard time traveling through these very, very narrow channels. So with time, the main artery that leads to the lung gets bigger and bigger and bigger, and the part of the heart that is pumping against that pressure starts failing. Normally, right side of the heart is very thin, it's small, doesn't have to do a lot of work because we've talked about the lungs being these very veil-like structures. So there doesn't have to be any pressure. You move the blood and it flows. When you have Raynaud's in the lungs, the abnormality happens. And again, there is some evidence that using the medications for the Raynaud's, like calcium channel blockers, has effect on that circulation, so that can protect your heart. So my plea is use your calcium channel blockers unless you feel really unwell on them. Think about them as the drugs that not only make your fingers comfortable and save your fingers from getting ulcers, but also save your lungs, save your heart, because the same thing happens in any organ in your body. And there are some nice case reports of a global heart dysfunction documented on nuclear medicine, which totally reversed with using of calcium channel blocker medication. So we've talked about interstitial lung disease, we've talked about kidneys, now we are moving to this vascular pulmonary hypertension. And again, the split. Your patients going 14 years who surviving 80% survival, which drastically changes if there is pulmonary hypertension. So the division has to be, is it the primary, is it the vascular, or is there also the fibrosis? There are, I'll skip this part. I think I'm getting some little signs here that I should be moving on, so I'll speed up. But these are the numbers that we look at, and if you have a pulmonary pressure that is abnormal and it's measured by the cath, survival is about 50%. This is important thing, preclinical. So all the testing that we are going to put you through, 6-minute walk, and some selected patients I'll ask to go on the treadmill and exercise. That's what I want to see. Do we need to do something? And at this stage, the recommendations coming from Europe are do treat with medications like bosentan or sildenafil. However, we don't have these meds available to us yet, but hopefully we will. So you see, this is the key moment to intervene. There, not here. These are the drugs that have been used in pulmonary hypertension. So bosentan, sildenafil, iloprost. And if you look, the magic line, you don't have to look at these numbers. You look at these big triangles. So there are various studies that look at it. And anything that is on the left-hand side is showing us that these drugs are working. And that's what we need to know. There's another look, different doses, different medications, meta-analysis. This is usually a very strong statistical analysis that tells us that the drugs are truly effective. And again, looking at what happens to the survival to the patient, because that's what really matters. With bosentan, 86 at 36 months, and at the same time, historical control from NIH, half of the patients are no longer with us. And quality of life goes up. If you do nothing, your walking time goes down. If you take medication, your walking improves. And more interestingly, there were 2 studies that separated different classes, class 3, 4, and class 2. And what it tells you, that the classes that right now we are observing, because that's what the peers are telling us, these do equally poorly, maybe not as badly as the class 3 and 4, but they deteriorate in years. So this is the patients who have hardly any symptoms, and they still are in trouble. Another drug helps you with reducing the pressure, improving walking. It's iloprost. We have it. We use it. Survival, in the past, 3 years, 35, now 65. Recommendations. So these slides will be available on the website, so you'll be able to study them. But we have strong recommendations for early use. Class 2. We really working in this group. So all these drugs, ulcers, bosentan doesn't heal them, but prevents them. 30% less. Again, not approved unless you have private payers. Helps with the hand function. And I put it as a curiosity. Mesenchymal stem cell revascularization. This, I didn't put the clinical slide because it was very not happy looking. But I put the angiogram. So there's no blood flow. These are ankles. So there's no blood flow past the ankle. Nothing. The clinical slide was total gangrene of the feet. After STELSEM, you can see that the blood vessels have reconstituted themselves, going right to the middle of the foot, and that blush here, you see all that? The blood is flowing to the fingers. So this is amazing. This is absolutely amazing. So these are the recommendations. Again, they will be there. They are from the Euler Scleroderma Research Group. Again, bosentan is coming strongly for ulcers, for pulmonary hypertension, early stages, and evidence is very good. A is always a good, very strong evidence. Skin involvement, they talk only about methotrexate, but in fact, studies with cyclophosphamide showed that the skin improves greatly with cyclophosphamide. So if there is, I've had one patient who for almost 2 years could not bend his arms to feed himself. He was up here for, so with cyclophosphamide, he softened up immediately. So all these recommendations are here: gastrointestinal disease, all evidence, and even scleroderma renal crisis. Not a lot of good studies, but there is expert opinion. So we're coming back to all these nice, colorful slides telling us about all these players and Mr. Clay and his autoportrait, which is very telling. And thank you so much.